anyway, in the next few minutes, I don't have a 3D or 4D echoes, but in the next few minutes, I'll summarize the importance of a portable TEE in diagnosing life-threatening conditions which can be treated very promptly based on the TEE findings. So the TEE is much better. It can be 2D TEE, much better than MRI or CT angio, which are also very popular, but they're not very practical. So sometimes in emergent conditions of the injured patients, very sick patients, it's very important to perform TEE so that we can make a diagnosis very promptly and treat it so fast, so that way we can save patient's life. Change my So the TEE is much better than other conditions at CT angio and MRI in diagnosing some life-threatening conditions such as aortic dissection. Sometimes people have aneurysm, leaking aneurysm with aortic dissection, and that only has few hours for the patient's life to be saved. And obstructive, sometimes cardiac tumors, atrial myxoma, and of course that's not an emergency, but it's important to make a diagnosis there. Now, obstructive obstruction of the prostatic valve with thrombus, and sometimes they can be in shock, and intracardiac thromboemboli leading to pulmonary embolism, and also rupture of the ventricle, again, which is also a great emergency. And sometimes in decelerating injuries, motor vehicle accidents, we have a rupture of the aorta, the so-called traumatic disruption of the aortic wall, which has only hours for surgery, because in a few hours patient may die if not corrected promptly. And of course, infective endocarditis causing vegetations to the brain and other parts of the body, and sometimes mitral and aortic valve stenosis, which may be missed on transthoracic echocardiogram. And after MI, some patients have rupture of the cardiac tendinae and papillary muscle, leading to mitral valve regurgitation and also shock. And endocarditis sometimes also can cause aortic regurgitation. So now, dealing with one of the most common conditions, aortic dissection. In dissection, the risk of death is great. Aortic dissection, in 25% of the aortic dissection patients, death can occur in 24 hours. In 50% of the patients, death may occur in the first week, and 75% during the first month. 90% of the deaths in aortic dissection may occur in the first year. So, of course, aortic dissection flap in the proximal dissection, most of the flaps are seen on transthoracic echocardiogram, but like this flap here, of course, you can see in transthoracic echocardiogram, but this can be missed. So therefore, it's important to perform a transesophageal echocardiogram. As you can see here, in the 50 degrees here transverse view, short axis view here, you see the true lumen here and the false lumen, of course. In this view, you can see the involvement of the right coronary artery. And in this 122 degrees long axis view, you can see the involvement of the right coronary artery. And similarly, true lumen and false lumen by TEE. And in this case, again, the false lumen involving the right coronary artery, you can see it. And of course, this dissection was confirmed by the CT angiogram. As you may see, the proximal dissection, type 1 dissection, seeing the proximal part of the aorta, ascending aorta, and of course, the extending all the way to the descending aorta. This patient was a 45-year-old gentleman with uncontrolled hypertension. He was my patient, and he came with a dissection. Of course, we confirmed that with the aortogram. He underwent surgery. Unfortunately, he didn't make it. So TEE was extremely important. Sometimes aortic dissection may occur after surgery, heart surgery. As you know, in this patient, this is preoperative echocardiogram here, no dissection. After the surgery, there was a dissection flap here. And here, a color Doppler shows true lumen and false lumen and no color flow. That's how you differentiate this from the artifact. Oh no, it's freezing here. And also, the traumatic disruption of the aorta in a decelerating injury of motor vehicle accidents are very important. most of these patients, it's not a very common injury, but when you see it, you might see widened mediastinum. Widened mediastinum is not necessarily due to aortic dissection. It may be due to hematoma, mediastinal hematoma. Sometimes there may not be any relationship between the aortic dissection and mediastinal hematoma. But it's interesting to note that most of these patients with a traumatic disruption of the aorta have a widened mediastinum. And the dissection in these patients is a different location. In the isthmus area. Isthmus is the junction between the subclavian artery origin and the first intercostal artery of the descending aorta, and that's where there's a junction between the mobile part of the aorta and the fixed part of the aorta, and then you might develop a spiral around the aorta, spiral dissection of the aorta. It is subadventitial, and if not corrected in a few hours, there may be a big hemorrhage, a large hemorrhage, and the patient may die immediately in a few hours. So it's extremely important to do TEE in these patients and diagnose the dissection here. And whereas these patients are so unstable with hypotension, shock, CT angiogram, the MRI may not be practicable. So TEE is very, very useful. And either diagrammatically, this dissection in this study by Vignon shows is a spiral dissection all the way around, subadventitial. Adventitial is the only thing which is holding the high pressure inside the aorta intact. And once it ruptures, there's a torrential hemorrhage and patient dies. So TEE signs of traumatic disruption of the aorta are as follows. There's the direct signs and indirect signs. Intraluminal thick stripe is all the way around the dissection. False aneurysm, that's very dangerous. Aortic occlusion, aorta may completely get occluded. Aortic dissection, intimal laceration, and fusiform aneurysm, so-called false aneurysm, wall hematoma, and there may be some minor changes in blood flow turbulences, hemomediastinum we showed. And TEE, sensitivity of the TEE to diagnose dissection is about 98% and specificity 95%. The advantage, as I mentioned earlier, close proximity of the esophagus with the thoracic aorta, and it's portable. Diagnosis can be made in 5 minutes, within less than 5 minutes. And in 2 unstable patients with hypotension, MRI and CT angio couldn't be done very promptly. And TEE also can differentiate true and false lumen. It can also identify proximal coronary artery involvement, thrombosis, pericardial fluid, pericardial blood, and other conditions. The only problem is disadvantages can be if there are esophageal varices, tumors, strictures, and of course sometimes there can be a bradycardia, bronchospasm, but there are minor problems. And this slide is a very busy slide, but here the sensitivity and specificity of TEE in emergencies is close to 98 to 95% compared to, in contrast to helical CT, spiral CT, MRI, 98 to 100%, in either case. So it compares very well with the MRI and CT angio. The other condition where TEE may be useful is, as you know, patients with, I had a patient, 25-year-old young man, he was passing out when he stood up. So, of course, this simple transthoracic echo showed atrial myxoma, but the TEE showed a huge myxoma obstructing the mitral valve completely. And, of course, that was easy for the surgeon to remove it. And this patient also, in the past, threw some emboli into the brain. And then I had a patient, a 78-year-old gentleman. He came with a profound hypotension, and he had a prosthetic aortic valve, and he has big problems of the aortic valve here. We gave him urokinase. He had multiple emboli into the whole body. In 2 days, he died. The surgeon, it was too late for the surgeon to take it out. It was big thrombus. And I had a patient, 48-year-old lady. She came with a heart attack, and then basically, and hypotension. TEE showed rupture of the free wall of the heart. It's getting freezing here. Sorry about that. Yeah. So this lady also had pericardial blood in the pericardium due to rupture of the heart. So anybody with pericardial blood, as you can see in this picture, after MI, that's not pericarditis. It's most likely rupture of the heart.